I'll be talking about screening for late and early stages of aneurysmal disease. And the World Health Organization has defined some criteria for screening of disease in general. And first of all, the condition you want to screen for has to be serious. It has to be an important health problem. And I guess we could say aneurysms is that. And of course, if you screen something, there has to be an accepted and established and proven treatment. And finally, the screening method has to be accurate. So I guess we could say for aneurysm screening, it seems that we have a potential case since the screening method and current treatment does appear to live up to WHO expectations. So let's look into it. Obviously, we're talking about using ultrasound, and you're very much familiar with this, so we can go on. Now, there's 4 randomized studies that have looked at the benefit of screening, and one of them happens to be Danish, so of course I'm going to show that first. And you can see here that this happened in Viborg County, where they invited 12,600 men above 65 years of age to screening, and of those, most of those who were randomized to screening actually turned up. And here you see the consequences of the screening with the invited group on the left side and controls on the right side, and you see the number of operations. The total number was, of course, biggest in those who were invited to screening. And of course, the number of elective aneurysm operations was much bigger than in the controls. And as you would have hoped, the number of emergency operations and ruptures were bigger in the controls. And this was, of course, highly statistically significant. And the most important thing is that there was a statistically significant reduction in death from aneurysmal disease, and almost also a reduction which was statistically significant when corrected for total death. And here you see the Kaplan-Meier for the risk of dying from an aortic aneurysm, and of course the dotted line is the control group, so you clearly see the benefit here. And this graph shows the effect on overall mortality. And of course, older men have other reasons to die, so the benefit is not as clear here. But as you can see, it almost reached statistical significance with a p-value of 0.51. So Fleming and colleagues made a meta-analysis in the year 2005 summarizing the 4 trials. The biggest one, the MASS trial from the UK, the Western Australian trial, the Viborg County, the Danish, and the Chichester also from the UK. And the overall result when they made the meta-analysis was that there is a 43% risk reduction on mortality from aneurysmal death. So very good data. Now, only one trial included women, and there was no benefit for women. So therefore, the recommendations from the American College of Cardiology and American Heart Association is that men of 60 years or older who are in close family relationship to other patients with AAA should be offered screening, and any man above 65 who ever smoked should be offered aneurysm screening. However, these trials are also old, 15 to 20 years ago, and we have the same issue as with carotids. They were not being treated medically very much. They were lucky if they got an aspirin. So with the knowledge we have today, could that have affected these trials? Well, let's have a look at it. Now, this is some data from the Danish National Vascular Registry where we looked at more than 3,000 elective aneurysms, and we then censored the mortality within 6 months of the operation and then compared to a sex and age matched control group. And you see here that the mortality in the aneurysm group was higher than the controls, even though they were distant from the operation. And this is, of course, because aneurysm patients have coronary disease, and they are, in fact, coronary heart disease risk equivalents. So the value of screening is not only do we have a major reduction in AAA mortality, we also identify a high-risk group of patients to whom we actually can offer medical treatment today. So is it only patients with big aneurysms that should be considered? Well, of course, for surgery, we know that small aneurysms, it's probably not beneficial to operate them, at least not all of them. But what else do we know? Now, these people here published a study a few years ago where they looked what is the effect of a dilated aorta on survival. And very interestingly, if you look at these curves, These represent aortas which have diameters from 2 centimeters to 3 to 3.5, and above 3.5. All dilatations which is much smaller than we would operate. But if you look at the curves, you can see that the mortality is increased by a factor 2, even with these small dilatations. So a dilatation of your aorta is sign of coronary heart disease, as is any other kind of atherosclerosis. So when you screen patients and you think you're only looking for the big aneurysms, an extra benefit is actually all the small aneurysms you find, whom you may then counsel for lifestyle factors and put them on drugs. Is it a big problem? Does it affect many people? Yes, it does. Big aneurysms affect more than 3% of men, and actually aneurysm rupture is one of the 5 most common causes of death in the men. So let's speculate on the value of medical treatment in these patients, and I made some speculations using the numbers from the Danish study. Now, in the Danish study, there was an annual mortality of 8 to 10% per year, and if you assume that you can have a relative risk reduction of 35% per year, and we know you can have that in any other kind of atherosclerosis patient, and we assume a prevalence of 3% per year, we would save 27 lives by putting these patients on medical treatment as well. And if you look at the number of patients who were rescued, who were saved by the aneurysm screening and concomitant elective surgery, that was 18 patients. Now I'm showing you that we would have additional 27 lives we could put on top of that. Now finally, does drug treatment have other benefits except apart from preventing heart attacks and saving lives? Yes, there was this recent meta-analysis of statin treatment effect on aortic aneurysm expansion. And you can see there were 5 studies that they quoted, and all of them were positive. And you can see that overall there was a 50% risk reduction of aneurysm expansion just being on a statin. So to conclude, within my time I can see, screening for aneurysm by ultrasound saves lives in men, not only related to aneurysms, but also certainly also from cardiovascular disease. Screening should not only be directed to finding operative cases. Any person with increased aortic diameter should be treated as patients with coronary heart disease. So the good news is that screening is twice as good as we used to think it was. Thank you for your attention.
Chamamos para comentar Dr. Márcio Miyamoto.
Bom dia a todos. Muito obrigado à comissão organizadora pelo convite e parabéns, Dr. Henrik, pela palestra. Realmente deixa pouca dúvida em relação ao screening. Bom, todos sabemos a importância, da detecção e do tratamento precoce do aneurisma para evitar as complicações catastróficas da ruptura. E hoje na literatura é bem estabelecido que a gente deve fazer o screening com ultrassom nesse subgrupo de pacientes entre 65 e 75 anos, geralmente quando eles são fumantes. Então, baseado nos índices de mortalidade relacionados ao aneurisma, o screening nessa subpopulação tem evidência de ser benéfica, né? Existe uma dúvida em relação aos pacientes acima de 75 anos, onde a expectativa de vida não demonstra tanto benefício assim para a realização do screening. Então, com o aumento da expectativa de vida que temos hoje, será que isso não seria benéfico você identificar um paciente mais idoso com aneurisma de aorta e tratá-la de uma forma menos invasiva? Aliás, essa é uma outra dúvida que a gente tem, que todos os estudos realizados em relação à mortalidade dos pacientes que foram submetidos ao screening é referente ao tratamento aberto. Será que o tratamento endovascular não mudaria essa tendência e prolongaria essa indicação do screening acima de 75 anos de idade? Outra dúvida que a gente tem também é em relação ao subgrupo de pacientes entre 65 e 75 anos, que as evidências hoje mostram que, se forem fumantes, existe um benefício do screening. E em relação a outros fatores de risco, como dislipidemia, hipertensão e também diabetes, se existe alguma evidência desse subgrupo de pacientes que não são fumantes, mas têm 2 ou esses 3 fatores de risco?
I'm not sure I can remember all of them, but let's begin with the one of screening older men. I totally agree with you that with the increased life expectancy and less invasive methods, you could question whether or not you couldn't screen people who are older. But the trade-off is, of course, that the older the people are, the less life expectancy they have, so therefore you will have to move your, you have to go for bigger aneurysms. It doesn't make any sense to treat an 80-year-old for a 5.5 centimeter aneurysm because he's going to die from something else than the rupture. But otherwise, I totally agree with you. But I would like to also to challenge the 65-year-old age group, and actually, why shouldn't we push it down? Because if you believe that identification of the earlier stage of aneurysms, just the dilatations of aorta, are important, as I showed you for cardiovascular disease, and yes, we also know this is an early stage of an aneurysm. And second, if you believe that drugs will alter the outcome of these small aneurysms, then we should ask ourselves, shouldn't we be screening maybe at 55 instead of 65, and then avoid people getting aneurysms after all? I think so.
Thank you, Dr. Sol.